So thank you for everyone that's joined us this evening. This is a part of our webinar series called Including Me that covers information, resources and support for all communities across Cheshire and Merseyside, and we are discussing key health priorities to improve women's health. Tonight's webinar is around twins and multiple pregnancies, and we've got some amazing guests to speak. But tonight I am joined by my colleague Decca. Would you like to introduce yourself?
Hi, I'm Decca. I'm Community Engagement Lead, Women's Health and Maternity Partnership.
And Benin, do you want to introduce yourself?
Hi, my name is Benin Saeed. Improving Me, Women Health and Maternity Partnership.
Thank you. And my name is Danny. And we are welcomed here with Jane. Would you like to introduce yourself?
Hi, I'm Jane and I work at Twins Trust, which is a UK national charity that supports families with twins, triplets and more.
Thank you. And Andy, would you like to introduce yourself?
Hi, I'm Andy Sharp. I'm a senior lecturer and consultant at Liverpool Women's and University of Liverpool, and I have been working in twins for the last 6 or 7 years now. So yeah, I'll be talking about some of the aspects around sort of the medical management of them.
Thank you very much.
So so yes, thank you very much for giving the opportunity to talk. We haven't got lots of time, and there's a few, so I've sort of cut back a lot of the aspects I was going to talk about regarding twins, and I'm sure many of those other aspects will also be talked about by Jane, particularly with a more perhaps patient-focused aspect than me as a clinician may necessarily always keep at the forefront, unfortunately, of my mind. I sometimes do slip up and become quite medical, but this talk will principally focus on some of the medical aspects around twins and twinning, and then I'll focus on 1 or 2 particular problems around monochorionic twins, or identical twins in layman's terms. And so there will be a fair bit of technical detail in this, but like I say, if you want any clarifications or anything, I'm very happy to discuss those at the end. So key thing really is that they're not that common, but common enough to have multiple pregnancies. And I will probably use the word twins more than I should. What we're really talking about is multiple pregnancies, so twins, triplets, quads, anything higher. And the reason I will say twins most often is because they make up the vast majority of multiple pregnancies in the UK particularly. 1 in every 65 births are multiple pregnancies. A little bit less common if with natural conceptions, and a little bit more common with assisted conception, particularly with IVF or some of the slightly less regulated forms of assisted conception, so with superovulation and stuff like that. Now, the UK has quite strict rules on that, and they're pretty good at trying to limit the numbers of multiple pregnancies, but other parts of the world may have a slightly more generous approach, which may lead to more multiple pregnancies, which can be very problematic, actually. The vast majority of twins are going to be what we call dizygotic. I'll come into that in a little bit more detail, and that does vary a little bit between different populations in the world. But I don't think it's too sort of important for us to worry too much about that now, but they make up the majority, or 2/3 of the type of twins we see. And then the monozygotic or identical twins make up about 1/3 of those, which works out as roughly 1 in every 250 pregnancies will be a identical set of twins. So in Liverpool, which is a big centre for twins and for pregnancy, of course, we see about 150 sets of twins per year. That's out of 8,300 births. And of course, about 50 of those are going to be identical twins, and 100 will be non-identical twins. So twins are exciting. They're very interesting. They generate a lot of joy, I think, when people find out they have twins. Sometimes some trepidation, no doubt, as well, I'm sure. The first question I ask anyone who's got twins is what type of twins you have, because having twins from a management of the pregnancy point of view is much more complicated. They do represent what we would call a high-risk pregnancy, and therefore they require a certain degree of advanced management, and the NHS is designed in its maternity pathways to do that. And there's been some recent advice updated from NICE just a couple of years ago, which also just confirms that twins aren't necessarily all needing to come to, say, a big hospital like Liverpool Women's, but they certainly need to have greater recognition of the potential problems that can come up, and they can affect both the mother's health, like we talk about here, some of these common conditions, or they can affect the babies themselves. So one of the really important things to understand is these really tricky words, really, zygosity and chorionicity, which are not particularly user-friendly words, I'll be honest, but they're really important when talking about multiple pregnancy and twins. So in general, the monozygotic twins is 1/3 of all twins. And the key thing here is that there is a single egg and a single sperm that has then split. And that means that these are genetically identical. So they have the same genetic material from the mum and the dad in each of the two babies. Okay. And that's really important because obviously if there's a problem with the genetics, then it will affect both of them. But also it's to do with, I'll show you in a moment, about how they might then actually look inside the womb and how they might interact with each other. And we use these different classifications, DCDA, MCDA, MCMA, and so on, which I'll talk about in the next slide. The sort of easier to manage sort of twins, if you want to call it that, are these dizygotic twins. And these are where you have 2 eggs and 2 sperm. So they're going to be genetically similar because the sperm presumably are from the same father and the eggs are from the same mother, but they're not genetically identical. And so effectively what you have here is you have 2 babies that are siblings, but just so happen to be living within the same uterus. But they're not really interacting with each other in any way. So they're sort of like 2 babies in bunk beds or something like that. You know, they're beside each other, but not directly having an influence. And these become much easier to manage because not only are they genetically identical, but it's to do with how their placentas work. And this is what we're talking about here. So here's your dizygotic twinning. So this is 2 eggs, 2 sperm. Here we go. And this is the sort of one that is influenced by things like IVF. If you put back 2 fertilized eggs, then you're more likely to have 2 babies inside the uterus. And you can see that they will implant separately, and you'll have 2 completely separate babies here, nothing to do with each other apart from sharing the same space. When we talk about the identical twins, the monozygotic ones, you can see you start with a single egg and a single sperm. They fertilize to make a new embryo, well, not an embryo yet, but what will become an embryo. And then it will split at different times. And this, if it splits very early, it follows the same pattern as this sort of twins. And what you end up with, dichorionic diamniotic, that means 2 placentas and 2 sacs. Same here, 2 placentas, 2 sacs. Now here, this could be a boy, this could be a girl. They could both be boys, they could both be girls. Whereas in this one, of course, they must be the same gender because they've come from the same single egg and the same single sperm. If they split a little bit later, then some of these structures will start to have formed already. So what you have is you have a shared placenta, okay? And if that's really important because these are much more challenging to manage. And if they split even later, they can even start to share firstly the membranes, and even later than this, it's not on this picture, even organs, which are very uncommon. And so if you look at the type of twins that you can get when you have a single egg and a single sperm, 1/3 of them will end up being, 1/3 of them will be dichorionic diamniotic, 1/3 of monochorionic twins will be, that's not right actually, sorry. 1/3 will be dichorionic diamniotic, and 2/3 will be either monochorionic with a single placenta, and of which the vast majority will be this type here seen on the picture, or much more uncommonly, they may actually have other areas joined, so either the membranes or even the organs themselves. So that's quite a complicated sort of thing, but it's really important to try and understand that if you've got a non-identical twins, they will be 2 completely separate pregnancies effectively in the same uterus, whereas if they're identical twins, 1/3 of them will be separate, and 2/3 of them will share a placenta. Now, this is how we look at it on the scan. We can determine this. We can't determine the actual genetics of the babies, but we can look on the scan and see whether they share a placenta. And to be honest, that's the bit that's really important for us on how we manage them. So here you can see there's a big wodge of placenta pulled up here. This is a dichorionic twin pregnancy, helpfully labeled A and B. And this one is a single placenta, despite having two separate sacs here. So this is a monochorionic twin pregnancy with what we call a T sign, and this is what we call a lambda sign. Why is that important? Because if we know what type of twins they are, then we can make an estimated guess of what type of zygosity they are, so whether they share the same genetic material, and that might be really important for knowing what sort of problems they can come up with, and I will come back to that later on. The other thing that's really important to know about twins is that they are associated with lots of problems, and some of those problems are genetic, some of them are to do with certain conditions. I'll talk about some twin ones, monochorionic twin ones later on. And also they can be associated with unexpected concerns at the end of pregnancy. So we always offer shortening of a twin pregnancy, and that depends on the type of pregnancy you've got. So the chorionicity, whether you're identical or non-identical. Because if you look here, we've got single babies in red. This is babies that pass away at the end of pregnancy, unfortunately. And you can see that for single babies, it's absolutely fine, really, very low risk of having a bad pregnancy outcome until you get to 40 weeks. But in twins, and this is quite old data, this is not recent data, there is a rise from much, much earlier. And this isn't split by the different chorionicities. And we see that by waiting, you increase the risk of a bad outcome for a twin pregnancy. But you have to balance that with an increased risk of a bad outcome for the baby if you deliver too soon. So this is that risk here again in blue with twins related to the gestation that you're born at, depending on sort of in utero problems. So you can see the sort of best place to really deliver is around 36 to 37 weeks, which is what we will offer people. So that generally is going to mean that most people with twins have their pregnancies intervened upon. Or at least the offer of their pregnancies intervened upon. And of course, that does, and I'm sure Jane might cover some of this as well, that does impact on people's choices and people's, where people can labour, for instance, how they labour and whether they choose to have a caesarean section or are advised to have a caesarean section. So how would you deliver twins? Well, there has been an argument made for all twins to have caesarean sections, and actually a lot of women with twins will choose a caesarean section anyway by choice. Some will be advised to do so, but actually there's no really good evidence that doing so is of benefit. And there's an argument that just leads to more over-intervention, reduction in skills and training for midwives and doctors looking after these patients for no real benefit for the baby. And because of that, we generally take a balanced approach to say, you know, there may be some clinical indications, but what does the patient actually want themselves? And if the patient is happy to accept the various different risks of whichever mode of delivery and it's suitable to do so, then we would support them in that. There are some general twin problems that can come up. So one of the main ones that probably doesn't get talked about enough actually is having your baby going into labor early and leading to an early birth. So about 60% of people with a twin pregnancy will actually deliver less than 37 weeks. Now, about half the time, though, that's because we tell them to deliver less than that point. But of course, sometimes it's because of going into labor spontaneously. The difficulty with going into labor early with twin pregnancy is that we know that we can assess who's likely to go into preterm birth, but we don't yet have decent interventions that are proven to be beneficial. So knowing someone's going to labor a bit earlier is useful, but it's not that useful unless you're going to have an opportunity to intervene in such a pregnancy. So really, one of the main problems on this short sort of lecture I wanted to talk about regarding identical twins or monochorionic twin pregnancies is twin-to-twin transfusion syndrome. Now, for medics who manage twins, this is a very important condition. We spend a lot of our time looking for this condition and trying to manage it. And the reason for that is because it's actually a really dangerous condition to get in pregnancy. And I know my lecture might be sounding a bit doom and gloom now, but it is because I tend to focus, unfortunately, on those with the more complicated parts of a pregnancy. It's not that common, thankfully, and it only affects those with an identical twin pregnancy who share a placenta, so the monochorionic ones, where I was saying at the beginning about them being genetically identical, and 2/3 of those who are genetically identical will share a placenta. And of those, about 10 to 15% will develop this condition called TTTS, or twin-to-twin transfusion syndrome. And I must say that the Twins Trust that James represents have some excellent patient information leaflets and support for people who are going through this sort of condition. Why it's a problem is because it's to do with the sharing of the blood flow between the single placenta. So by only having one placenta, the baby's blood does mix between the two babies. And that's fine if it's even. But what can happen is you can have the arteries for one baby and the veins from another joining. And because of that, arteries push under a high pressure and therefore push blood preferentially into a vein which is under a lower pressure. So what that effectively means is that one baby will give away some of its blood. So this baby here will be the donor, and that's giving away some of its blood to this baby, its sibling, who becomes what we call the recipient. And why that's important is if you've got less blood in your body, same as if one of us lost some blood for some reason after an operation or something, what would happen is that your body's not stupid. It would try to preferentially keep that blood in the best places. So that's going to be your brain, and it's going to be your heart. And it would do that at the expense of your gut, and it would do it at the expense of your kidneys. And that means that this baby, the first thing we see on scan is that there's less fluid around this baby because it's sending less blood to its kidneys, so it makes less urine. Whereas this baby's getting extra fluid. And the same if one of us had a drip in and was given liter after liter of fluid, we'd be fine, but we would definitely need to go to the toilet soon. And so because of that, this baby produces a lot more fluid. So we can see this difference between these two areas. And if that were to progress to its highest forms, it actually is very, very dangerous for both the babies, particularly this baby that gets extra fluid, but actually for both. And untreated, if it's at the advanced stages, it will actually lead to one of the babies passing away in about 90 to 95% of the time. So that's a very serious risk, actually, much higher than most risks that we consider certainly in pregnancy. So, this is what it looks like on scan. So this is the extra fluid around that recipient baby. And this is the small amount of fluid around the donor baby. And actually this example here, you can see this is the donor baby. It's the same way around, thankfully. And this is the recipient baby. And there's actually no fluid. You can't see any fluid at all around this donor baby. We use this staging here to tell us about the fluid around the baby, whether we can see other features. I won't go into that too much. And we offer an intervention which we've just started to offer now in Liverpool as well after hiatus of some years. And we use what's called a fetoscopic laser coagulation. And how that works is you've got your placenta with your two cords from each of your babies. You have a line across it effectively where the equator or where they meet, and you find the blood vessels and you buzz them as you go along, preventing the connections between the two babies, and therefore stopping the twin-to-twin at its point. You don't undo any damage that's been done, but you do stop it from progressing any further. I might just if it's okay, I know I'm probably running over. I just want to see if this works. I'll run a very short bit of a YouTube video because I think it really helps to understand what this means. Now, we'll just cut through to the bit that's important. He's a nice guy, but I don't want to listen to him at the moment. So you can see we're inside the uterus here. We're actually inside. This is a baby looking at its face here.
We can only see your presentation.
I don't know if I can turn the sound off that, but oh, there we go. Can you still hear me? I don't know if you can hear me. No, you can't hear me at all. So here
but we can't see the video. We can only
you can't see the video?
No, we can only see your slide.
Oh, that's no good. That's not working. Okay. Sorry about that.
Don't
I
worry.
will come back to my, let me see if I stop that share. It is worth seeing. So if I can come back to, it's because it's jumped, here we go. It jumped to YouTube. So if I quickly go to, now you can see it, I think, correct? Yep. So let me just go back a little bit. This is a guy in America talking. But you can see we're inside the uterus here. This is the baby's mouth and nostrils. This is the liquor, the fluid around the baby. This is the cord coming. Can you hear me still? Yeah, okay, good. So
Yeah,
I've shut
I can
him
hear
off.
you.
That's good. So these are the blood vessels he's looking at here, and he's trying to follow down to see where they join. So we've left one baby and we're joining the other. This little white line, that's the actual folded membrane. We said that it was collapsed, didn't we? And he's found a little connection between this baby on the right and the baby on the left. And he's just buzzing here to block up these little vessels that are connecting between the two babies. And this is, it's actually in some ways very simple, but it's obviously very complex to be going inside the uterus, and unfortunately does come with some risks as well. So we'll just stop that now. Let's come back to this last couple of slides. There we go. Great. Well, I hope we got there in the end. So this is what we do. We pass the camera inside. You can see these blood vessels, and it's very good, but it's not perfect. You can see that unfortunately there is still a risk of losing one or both of the babies despite this technique. And as a technique, this sort of level of losing a pregnancy, I don't think anyone is really happy with. It's a very successful technique, but we would like it to be much better. But unfortunately, it still has a significant risk associated with it. So we reserve it only for those cases where we think the benefit outweighs the risk. The only final bit I wanted to do, because I just realized I'm conscious of time, is I just wanted to give you an explanation of what we do here in Liverpool. So we have a multiple pregnancy clinic that's been running for more than 20 years. It has a one-stop shop approach to the clinical service it provides. There's myself and Professor Asma Khalil, who has just joined us. She's worked in London previously, and she's just joined us in December. And one of the things that she has brought in her skills is not only a vast experience of twin pregnancy, but actually we're now offering that laser intervention, like I said. And we had our first case just before Christmas, which has been very successful, and that is now a happy ongoing pregnancy. We have a team as well of other medical staff and midwifery staff, those who work in fetal medicine. And we have 2 twin specialist midwives who provide the antenatal care to our twin patients. And that allows us to manage these 150 sets of twins per year, plus extra referrals that are sent in. We perform the laser ablation I've mentioned, and also we do screen people for preterm birth risk, although that's not part of normal national guidance. And what's really important is that the role of the midwife that we provide, the specialist midwife, is to maybe provide a more holistic approach to the care. You've got the medical team to do the more sort of complex bits when pregnancies deviate from normality, and then you've got the specialist midwife who forms that anchor between the pathology and between the experience for women, providing support, acting as their advocate, and understanding that this is not, like a lot of pregnancy things, it's not a pathology to be managed by doctors. It's a part of a process that sometimes has pathology and has to have significant involvement, but for a lot of people is a very important part of their journey and their life, which may be their first and only pregnancy, or maybe their fourth or fifth even, but nonetheless it's usually their first twin pregnancy, and that poses challenges for them to how they might adapt and how they need to feel empowered in understanding what they are going to go through, not only in the antenatal period during delivery, but also after delivery as well. So I've prattled on a little bit long, so sorry about that, but I will hang around for questions afterwards.
Amazing, thank you for that. That was really, really interesting and very informative. So thank you very much.
Right, so as I said, I work for Twins Trust, and we're a smallish charity, but we do work right across the UK to support families. So as Andy's already said, you know, having a twin pregnancy, it is higher risk and it needs, you know, a lot more care during the pregnancy. So we support families all the way through from the pregnancy when they first find out until, you know, hopefully they take home sort of 2 healthy babies, and then help them through those early years and all the way through the journey, because having 2 babies at home as well, 1 baby is difficult, but 2 babies or even 3 or more, that puts a whole new level of work and stress potentially on a family. So what I want to do today is just talk a little bit about how Twins Trust can help and support both families, and also how we support healthcare professionals as well to give, you know, help ensure the best outcomes for our multiple families and give them the best start in life, and also, you know, the best progression. So to begin with, we have a number of resources and booklets and leaflets on our website as a first point of call for parents when they find out that they're expecting, you know, twins, triplets or more. It can be quite overwhelming for some people. They were hoping for a baby and find out they've got 2, and that's perhaps not what they were planning. So it may not always be the best news for some parents. So sometimes people are not expecting that and don't have the reaction that they think people expect them to have. So what we do is we, you know, offer a lot of information, because sometimes people just want to know what's happening. Because the pregnancy is higher risk, as Andy said, you have more appointments and you'll have more scans. And what we're really keen to make sure is that all parents understand what it's, you know, that their pregnancy is going to be slightly different and managed in a slightly different way. So our Healthy Multiple Pregnancy Guide sort of details out what happens, what to expect, how your body changes, and how it would be different if you're only expecting 1 baby. And we have care pathways as well. So just so you know, depending on what type of pregnancy, Andy mentioned whether you've got 1 placenta or 2 placentas, you'll have slightly different numbers of scans, different numbers of appointments. So we cover all that just so everybody knows and understands what is actually happening and what to expect at that appointment. We've also got booklets that cover preparing the practical side of getting ready to take home more than 1 baby. So whether that's, you know, sort of cots for sleeping, or, you know, pushchairs and prams and everything else that goes with it. Obviously, feeding more than 1, you know, it can be different. So we offer feeding, whether it's breastfeeding or bottle feeding or mixed, some support and advice on how to do that. And also, as we've covered, because they are higher risk, they're more likely to be born early. You know, your babies are more likely to need some neonatal care. So we have a lot of information there just to prepare people for what happens if your baby needs to go into neonatal care, what that means and around that. And also the complications that Andy mentioned. So just so parents know what to look out for in terms of some of the signs and symptoms, and again, explain and also hear stories of other parents that perhaps experienced some of those conditions. So all those are available as booklets, as hard copies, or on our website, so for people to access. So everything that I'm talking about today is you can see through the Twins Trust website. We also have leaflets as well, so we cover things about once babies are born, about safe sleeping, how to safely make sure if you've got more than 1 baby, how to, you know, when not to put them together to keep them safe, and also things about postnatal depression, or people that aren't, you know, are suffering after the birth. We also have an awful lot of courses. A lot of some of the standard courses offered by either sort of a hospital or through other groups are offered for a singleton pregnancy. So we recognise that obviously that there are other things that we need to talk about. So we have an early pregnancy workshop, antenatal classes, preparing for parenthood. You can see them there, breastfeeding, sleep, everything that covers the twin or triplet angle, just to give you that more information and help you prepare and sort of take some of the anxiety, potential anxiety away from expecting more than 1 baby. So those are all on, there used to be a lot of them face-to-face as well as webinars, and because of COVID we now run and will continue to run a lot of them online, which makes it easier to access as well sometimes if you're struggling to get out and attend in person. So there is a number of different courses that are all bookable through the website. We also have a number of areas for supporting online or via our helpline. So Twin Line has been going, I think it's about 30 years now. So it's a support line that's manned by twin parents, so they understand some of the things that people are going through, whether it's just somebody to talk to, or just feeling, you know, things are a bit difficult, or just getting some advice about a certain situation. Twin line is there, and it's open every day of the year apart from Christmas Day, and it's also, you can email any queries through on the twin line and the email address there. We recently opened a community forum, so again, this is for parents to talk to each other. Anybody can post on about a new topic just to get advice or just to discuss a particular area. So that's quite widely received and is growing, you know, growing on a weekly basis. And we also have Facebook closed user groups. So we have groups for special needs, with children with special needs, and single parent families, and even grandparents as well. So they've all got their own small closed user groups for people to join. And again, just have a discussion amongst other people who are going through or in a similar position as yourself. So a number of ways in which we can, you know, support parents and give them people to talk to, or talk to other people in a similar situation. And sometimes things don't always go, you know, the way you want things to go. Parents may be struggling with at home with the arrival of their multiples. There might be severe medical needs that for one of the babies, that means time is needed to be spent in a neonatal unit with one baby and one baby at home. Or just any other sort of severe need or crisis that a family may find themselves in. So we do offer a crisis support service. We work with Norland Nanny to offer actual practical support on a short-term basis, just to try and go into a family to help support them if they are in, you know, in severe crisis and in severe need. There is a certain criteria to be eligible for that support, but that's all there. We also offer a sort of a high-level, more practical type of support as well, just for people that are sort of struggling to cope and struggle to get into a routine with having you know, sort of newborns, twins, triplets and more back at home with them. And also, sadly, not every parent is able to take their babies home with them. You know, with every pregnancy, not all pregnancies result in a good outcome for the baby. So we do also have a bereavement support group, and it supports all parents and carers of twins, triplets and more. And that's whether they die during pregnancy or at any point after pregnancy. We have a number of befrienders that have all experienced a different type of bereavement, so we can pair those up with parents that have experienced that and just to help support them through that really difficult time. And again, there is a booklet that's available, but more information in a closed area on our website about our bereavement support that's available. So that's a real sort of short capture in terms about supporting parents. And I think one just point I wanted to say is about the care in your antenatal care, how important it is to have all those extra appointments. It can sometimes feel like you're having an awful lot of appointments, an awful lot of scans, but that's just so the healthcare professionals can keep a real close eye on what's happening during the pregnancy, and if there is a problem at any point, pick it up. And they'll also talk to you about what type of birth you'll have. So sometimes the options aren't perhaps all the options you'd hoped for when you're having more than one baby, but the only reason for that is because they just need a bit of extra care and a bit of monitoring to make sure they get the best outcome. But those discussions will happen during your pregnancy with your healthcare team, your midwives or your consultants, just so you understand sort of what your birth options are and talk about what type of sort of birth you'd like. So we, as I said, we support parents and we work with healthcare professionals as well. So we have a maternity engagement quality improvement plan, and we work with a lot of units and both supporting and working with them as somebody that's best practice. So we've worked with Liverpool Women's. In fact, one of the Liverpool Women's midwives helps us support us on this programme. So we go into different units around the country and around the northwest, Liverpool and Merseyside, and we try and work with maternity units just to make sure that the care that they're giving is the best care that's there because of these high risks, and that people understand how to spot if something's going wrong and how to deal with it. So we've been working with over 40 units now, and we started this programme over 5 years ago. And what we've really found out that following the NICE guidelines that are there for how you manage a multiple pregnancy really do work. By following the guidelines, you get better outcomes. You get reduced stillbirths, you get reduced neonatal deaths, and you also get reduced neonatal admissions and emergency sections. So it's, you know, all round, there's the evidence is there, and the little infographic on the screen there just shows what sort of results we found 2 years after working with the initial group of units that we worked with in England. As I said, we offer a lot of CPD learning for healthcare professionals. We have a separate area on our website dedicated for healthcare professionals, which is free to access, just a brief registration. And there's a wide area of resources there. As I said, a lot of CPD learning, videos of study days and different webinars. And each year we have webinars and study days completely dedicated to different aspects of a multiple pregnancy, antenatal care, complications, the sonography side of it, the role of the specialist midwife, and also through to you know, the intrapartum care, the delivery of the baby, and neonatal care afterwards. So we cover all aspects of a pregnancy through to delivery in the early weeks. We also offer peer support to units, so units that have taken part in our maternity engagement programme, we can put them in touch with other units of a similar type of size and number of pregnancies that they see, just to help give them some advice and talk through how they manage to build a better service to better support the families. We also work with NHS England. We've worked closely with them for a number of years, again, trying to make sure that twins and triplets are represented in care in all the maternity initiatives that go through the UK. We were really pleased, well, in England, we were really pleased this year that we've got inclusion in the maternity incentive scheme, which is quite significant. So we've now got twins explicitly mentioned in there, which again, all this helps to drive through better care. And as I mentioned, these care pathways, we have them endorsed by NICE, so they're there for health professionals to use if they don't have one in a unit. And as I mentioned, we do have a parent version of that that explains, you know, what's going to happen at each scan, when the scans and appointments are going to be, and what's going to happen at each appointment. And that was updated. They were updated after the 2019 update of their NICE guidelines, and they are on the NICE website as well. So yeah, we do work very closely, and this work continues. We will continue to work with all units until all the units are offering the best care they possibly can for twins, triplets and more. The last sort of element that we do, we also support research. So what we want to do is to understand, so you know, there still is a lot of unknowns about you know, a twin or triplet pregnancy and how we can manage, identify and manage some of these complications and just learn more. So we support, whether it's clinical research into things like that, that we do support, and also do some of the priority setting in terms of what we're seeing as the key areas that we want to focus on first, just to understand a bit more about how we can, you know, these complications and how we can sort of manage and treat them. We also, as well as the clinical side of research, we also look on health reports and also the impact on family and relationship in terms of what, you know, what a twin, having twins or triplets, the impact that can have on families' relationships and also finances for a family. We offer, so we work jointly with an organisation called the BMFMS, the Fetal Medicine Society, to offer bursaries, again, to help do support extra research. And we have a Centre of Excellence partnership with St George's Hospital in Tooting, again, where we can help to offer peer support for the units via St George's, and also some other learning there. So we really try and support our parents directly, but also help support the health professionals to give the, you know, the best care and the best outcomes. So that was a really sort of whistle-stop tour of everything that Twins Trust does on all the many aspects of it. So I think Benny's going to open to questions, but if after the session, please do contact us either on the email address there or look at what's the information that's on our website.
Amazing, thank you so much, James. It seems to do an awful lot, which is great. I think it's really nice to see, because I don't think I'd seen how much you actually did until it was, you know, put in front of us. So that's really good. Thank you for that. Does anybody have any questions or any comments or stories?
Yes, Danny, you know, I am a mother of twins myself, and I can really see when, you know, you are so worried when the midwife tell you have a twin and you don't know what to do. Oh my God, what can I do? 2 babies on the way. And it was very, very important that I had those monthly meetings with my midwife, and she was herself a twin, and she had twins, and she explained to me that was okay. And I was scared, I was saying, oh, will I have C-section? And she explained to me, no, it doesn't matter. You can have normal delivery. And I remember that without that reassurance, my mind will go up all the way. So she reassured me, and she showed me picture of how to breastfeed two twins. And thanks to that, I can really, I wish I could see her again. And I had a normal delivery thanks to her reassurance mostly.
That's really good to hear.
I think that's a really good example, actually, and I think it is really uncertain. And unlike a lot of, I think there's an awful lot of peer support from your friends and relatives in any pregnancy, but twins is tricky because they're just not that common. So most people that you know will not have had a twin pregnancy. So you really do need that specialist insight from particularly midwives who work with twins, but those our two midwives in Liverpool have either been a twin or they have twins themselves. In fact, one of them is one I think you're mentioning this. I don't think you delivered at Liverpool, did you? She is a twin and she has her own twins as well. And if you haven't got that support, then that's where the Twins Trust performs a really, really valuable service, because twins just aren't that common, and smaller hospitals, then they're even less common, of course. So even the staff looking after you won't necessarily be as familiar with twins as they are with a single pregnancy to manage. So I think that's a really important point that you've highlighted there.
Thank you. And it was the women's that she gave birth in.
Yes.
So it's really good. I'll go to Hope and then to Bani. Do you want to bring yourself in, Hope?
Hi, Danny. Can you hear me?
Yeah, we can hear you.
Hi, I'll also share my screen. I don't sound like you guys. I'm in America. I'm having twins, but there's not a lot of resources for us. So I came across this event and it is so refreshing. I have loved listening to everything. Jane, especially hearing that you guys have this organization specifically for twins and multiples. We don't have that here, much less events like this. Obviously twins are super scary, but it's all going to work out. But I'm super excited to go check out the Twins Trust website and see what I can get from that. And even Dr. Sharp, there's, they don't give you a lot of information over here on, I know that I have Di twins and they're fraternal, but that's about all I know. They just don't expand on that information a whole lot. So this has been really great. I don't necessarily have any questions. I'm 29 weeks today, so things are getting a little further along. We're starting to talk about delivery and what's going to happen that way, but I don't have any questions. I just had to thank all of you guys so much because, like I said, resources are just so limited in the States for twins and multiples. So thank you guys. I'm excited.
It's great to get your feedback, Hope, and I think that's one of the most important things. It can be scary, but I think if you get the more information you can have and look at, then I think you feel a little bit more in control and feel like you know what's happening a bit more. So yeah, please do go and have a look and read through some of the resources, and we'll look. Yeah, not long to go now.
I would echo that, and I'd say being informed is one of the most important things to empowering you to feel comfortable about the decisions that you make in consultation with your midwifery and medical teams that are looking after you. But it is always a dialogue, and I think that's I wouldn't want you to get the impression that the UK is necessarily perfect on things like this, because as Jane pointed out, one of the things that the Twins Trust has been working very hard on is trying to make sure that the standard is brought up in UK units. So, but I think just because you're in a different country, the resources that Twins Trust particularly have are accessible nonetheless. They're all available to download or read as PDFs. So that should be 95% perfectly adaptable to another setting. There'll be some slight differences, of course, but they'll be very, very minor. Good luck with everything.
Yeah, no, thank you guys. That's awesome. That's it for me, Danny.
Thank you.
Oh, thank you for coming along, and especially with the time difference. So thank you. Vinine, do you want to come bring yourself in?
Yes, my question is it something to do with genetics? Because I've heard that if you have someone in the family that had twins, then you have the chance.
So certainly for the non-identical twins, there are some clusterings within families for sure, and within some ethnic groups. So one famous one is in Uganda. There's a population in Uganda where there's a much higher chance of having these dizygotic or non-identical twins. So it's probably genetic, to be honest. You know, when we talk about sort of regional and ethnicity differences, we're really talking about genetics there. And so probably you've just got a higher chance in that population of ovulating more than once, because that's what you're talking about here, is just throwing off more than one egg. The default is to produce just one egg every month. That's why most pregnancies are just one baby. But occasionally you can always produce more than one. And the other thing that skews that, of course, is not genetic, but is intervention. So when medicines are given to make you ovulate more, which is one of the first parts of having assisted conception or having help to conceive. So yeah, definitely that case. But when you're talking about identical twin pregnancies, then they are sporadic. They don't have any relationship with different ethnic groups, parts of the world, IVF, any of that sort of stuff. They are just seem to be what that, and no one understands why, but what that fertilized egg decides to do in splitting itself seems to be in the lap of, well, whatever you believe in, to be honest.
Thank you so much. Thank you.
I'm going to ask it's a bit of a random question compared to some of the others, but it's just had me thinking about around the bereavement side of things. So very, very early on in my pregnancy with my middle child, around about the 7-8 week mark, I began bleeding quite heavily. And in that, they mentioned that it was probably a twin. But what I'm thinking is, what kind of things do they look at? How would they know that early on? And obviously nothing was said after that. It was a case, you've got a healthy pregnancy, everything's fine, move on. But it just got me thinking, do I even need to know that information? Probably not.
Yeah, I think that's a really tricky one, to be honest, and still that sort of comment does get made a lot. I can understand why it got made a lot, maybe 15, 20 years or more ago, when we weren't scanning anywhere near as frequently. So we in many ways had no idea how many babies were there until much later in the pregnancy, and obviously sometimes not even until delivery. If you're going back to sort of pre-1980s, then you would literally just find out how many when they were born. Now with ultrasound being as common as it is, I mean, it's very uncommon for people not to get an early scan as soon as they have bleeding, in the UK at least. Then I think we probably use that term to say, like, a vanishing twin is sometimes what's said, or it used to be a twin pregnancy and now there's just one. I think often there probably isn't the evidence to support that. You should still be able to see something on scan in most cases. I'm not saying all cases, but I think that term probably hangs around longer than it should now. But certainly it can happen that some pregnancies can start as 2 and very quickly end up as 1. And if you didn't have an issue and you presented for your dating scan, may well just look like 1. That definitely can happen. And it's very challenging for people to understand, because it gives you an answer, but it doesn't really give you a reason for the answer. I mean, then you're worried about, well, okay, now was I carrying 2, and now is there a risk to the 1 that still remains? I find it quite an unhelpful thing. I don't know how you felt at the time, Danny, but
yeah,
it sort of doesn't answer anything.
Because it was more like, you know, I understood that he was fine, and they said they could see everything was healthy and it was where it was and stuff, but it was just in my mind of thinking it was so early on that it's like, and because they don't offer any support afterwards, because it was quite a flippant comment as well, it was almost like a case of, did I really need to know that information? Because I probably didn't at that point in time. So it was just a bit interesting to see what evidence did they have at that point, because I would have assumed there wouldn't be much to see.
Jane, I presume you get lots of people ringing you about this, don't you?
Yeah, well, interesting enough, it was actually a midwife that contacted us just last week about this very thing. And in this case, the woman had to have an early scan, so they had detected 2 sort of embryos. At a later scan, there was only 1 baby visible, and there was no sign, which is, you know, the very point that, you know, it had began as a twin pregnancy. You know, 1 embryo hadn't developed, and there was no sign. But I guess there may have been, and as I understand, there may be some evidence that later on, but it was then presenting as a single pregnancy. But because she'd had the early scan, so and to treat that, I mean, that is, you know, it is a type of miscarriage. So it's just in terms of the bereavement and the support mechanism, it's just it needs to be dealt with as any other miscarriage or bereavement. The fact that it was early on and hadn't developed, and you've still got 1 baby, it is still a bereavement and a miscarriage that needs to be dealt with, you know, sensitively.
I think that's a really important point that Jane raises there, and it comes up at we talked about other complicated twin things that can go on, and Jane was talking about, you know, unfortunately not everybody who starts with twins ends up taking home 2 babies, and so that there is unfortunately inherent in twin pregnancies that there is a real risk of having to grieve for 1 baby, yet possibly have another one immediately in front of you, or maybe not even with you for some weeks or months yet, and so you're grieving for 1, yet trying to be optimistic about the other, or deal with the one that's crying in front of you because it's a newborn baby needs your care and attention. And I think that must be very, very challenging for people to deal with, and it's really probably very difficult to, outside of specialist services like Twins Trust, to get the sort of support, because no one's really used to talking about it. People are used to talking about bereavement, people are used to talking about healthy pregnancies. They're not usually used to dealing with both aspects together.
Yeah, and I think that's just a challenge in general, because I suppose as a mum, you don't know how you're going to react either, and you know, and whether you want that support from that point of view, especially like from the early miscarriage side of things, because some people will be a case of, well, what will be, and I've got a healthy baby, and then there's others that, you know, will understand that it really is. So it's so, you know, individual on how they're going to react to that as well. So it's just catering and asking the questions, what kind of support do you want, isn't it, I suppose, and again, just signposting them to the Twins Trust and other bereavement to help them support if needed. And
I think it's inherent in all of us to feel that we should be positive about a birth and a child. You know, it's an important part of human development. We're all here because somebody decided it was a good idea at some point, and I think all of our friends and peers are all also sort of designed to be positive about that, but it must be very challenging when you have on one hand a positive outcome and on the other hand you have a very negative outcome, a sort of outcome that you would never want to consider in any pregnancy, really. And the clinical team looking after you, your friends and family, it's very difficult to find that right balance for you. Probably no one finds the right balance all the time, I would think, but it's an evolution of how you deal with that yourself. And I reckon what's really important from a bereavement team point of view, we have a bereavement team in Liverpool, like most trusts do, and obviously with Twins Trust as well, and other palliative services. So we have one called Clare House in Cheshire and Merseyside region. One of the things that they very much will focus on is that you don't focus all of your attention on either of the babies, really, that you try and recognize that both of them are an important part of this pregnancy and your family. And even though one may not be there with you longer term, it will remain a part of your family and that experience. And some people will tell the surviving child about their sibling at an appropriate point for them, so that it becomes something that they accept and is a normal feature, even though they never met their sibling. And I think that's a really important thing, to try and make the balance right for each individual family. And one family might want lots of things, memorabilia and so on, so mementos, sorry, whereas others may want nothing to do, and each is right. You know, neither of them is wrong.
Absolutely, thank you. So just before we finish up, has anybody else got any questions, comments, marks, or anything from in the audience? think we've stunned them all into silence. It's a good thing. So yeah, that was really, really interesting. So thank you to both of you, because that was really good, and we'll certainly be putting more resources up for the Twins Trust to signpost to as well, on our website and things as well. So that was really good. So Benin, Decca, do you have any final remarks before we close up? Jane, do you have any final remarks before we finish?
No, nothing from me. Just it's lovely to be able to talk about the work that we do at Twins Trust.
Brilliant, thank you. And Dr. Sharp, is there anything that you would like to bring up?
Only that it's a really positive experience having twins, and I know there's a lot of negatives and things that can go around it, but the structures are there to deal with those more complex things that can happen, but actually the vast majority of pregnancies will be fine and supported and have a good outcome, and to be positive about that, that's the key thing. Absolutely,
yeah. Well, thank you all very, very much appreciated for your time. I know how busy you are at the minute. Thank you to all that's attended, and we look forward to seeing you on our next webinar.
Bye all.